everybody. Welcome back to another episode of Honestly Bilal. I'm your host, Bilal Ahmed, and I'm a fourth-year medical student at the University of Toledo. And this is Honestly Bilal, the show for the aspiring ophthalmologist, where I sit down and talk with medical students who are interested in ophthalmology, with the residents who are training in ophthalmology, and with current ophthalmologists in the field today. And today I have the honor of being with Dr. Steve Houston. Dr. Houston is a vitreoretinal surgeon and partner at the Florida Retina Institute, and he is the CEO and co-founder of HealTheia. So Dr. Houston, it's a great pleasure to be with you, and thanks for joining me.
Thank you, Bilal. I love what you're doing with the show, and I hope I can provide some further insight into all your listeners and medical students so that they can see what a great field we've chosen.
All right. So, let's talk about your process when you chose this field. A lot of medical students who may be out there, maybe they probably have heard of ophthalmology or they want to learn a little bit more. And I think, learning from your story or other stories is a great way to kind of see how we can all develop our own paths. So, what was your origin story in ophthalmology and in retina? What got you into the field?
Sure. So, I think what you'll probably hear from a lot of people is there's either some kind of experience or encounter that kind of pushed them or got them initially having a taste of what ophthalmology was, and then they were able to explore it on their own because, as you know, in medical school, there's not many rotations, or if you do get a rotation, it might be a short 2-week elective and that's not enough time to really get a full feel for what ophthalmology has for it. So from my standpoint, I started off in undergrad knowing I wanted to go to medical school, like, a lot of pre-meds, but I was also very interested in engineering. And so I was, from the beginning, interested in kind of combining the two so that I would do medicine, but with a underlying focus in engineering, which I thought for me would be a perfect kind of blend of the two. I think a lot of people go into undergrad, choose biology, chemistry, thinking that, will set them up well. But I was always more kind of the math-oriented, physics-oriented type of kid. And with that interest in the biological sciences, how the body worked, anatomy. So for me, going into undergrad, I wanted to not only do pre-med, but really wanted to focus on engineering because I thought that would set me up well even once I got into medicine. So I went to the University of Florida. I graduated with a materials engineering degree. Took a lot of computer science classes and thermodynamics and materials, polymer science, at the early time with drug delivery systems with polymer materials. So that initially got me really interested in medicine in general. But then I had the chance to encounter that during one of my summers when I was on campus taking some of my engineer courses, electrical engineering and some of these others. I thought, hey, I've got some extra time here. I wanted to work for a doctor. So I was searching around for opportunities, and just so happens I found a great opportunity to work for a ophthalmologist as a technician. So during the summer, I worked for about 3 or 4 months while I was taking classes and applying to medical school for an ophthalmologist. Working on that, I got to work up patients. I got to do visual field testing. I got to see, early OCTs, and really started to get a feel for how technology played an important part in what ophthalmologists do. This is a glaucoma specialist, so, we were doing a lot of visual field testing. And back then, before OCT, there was a GDX device, which basically was a way to look at the optic nerve and determine if there's any type of damage there. So I quickly saw that it was, more than just a field that was, checking labs and, being in the hospital, but that you could really incorporate a lot of the exciting technology into it. So that initially gave me that spark to say, all right, ophthalmology is pretty cool, but, I was a big athlete. Even during residency, I did a few Ironmans. I still do a lot of running. I'm a huge snow skier. So, anybody that's into sports going into medical school, you probably hear that, hey, I'm going to look at, orthopedics, and I was even interested in some of the microsurgery with hand surgery within it. But I got to medical school, and I had in the back of my mind that ophthalmology was interesting to me, but I wanted to say, all right, I'm going to give this a fair chance. I'm also interested in orthopedics and specifically hand surgery. And so I explored those opportunities in med school, but I kept coming out of it saying, well, that just didn't catch me like ophthalmology did. And so early on, about second year into medical school, I was starting to pursue, I pursued some opportunities in orthopedics with some other doctors, but then at the same time in parallel, I was pursuing opportunities in ophthalmology. And quickly, I realized I had much more of a passion for the ophthalmology than I did for the orthopedics. So around second year, I decided, hey, I'm going to really go into this more significantly and started searching out, mentors and opportunities within that realm. So I was lucky enough to, find myself to medical school at University of Virginia. Really found great mentors in Steve Newman, who's a neuro-ophthalmologist there, and then also Nicola Ghazi, who is a junior faculty, but in retina there. And so I got to work with them, really see all the technology. And it was also an exciting time because that was between 2005 and 2009. So as you know, with retina, that was the era where OCTs were coming on board. We started to have this new medication called, Avastin for, anti-VEGF. And so it was really an exciting time to see and spend time as a medical student with some of the retina docs there to kind of, look at, oh, wow, these are some amazing new imaging technologies we can do to get a virtual biopsy of the retina. And now we can actually treat some of these diseases with medications. And then spending some time in the operating room was really nice to see, cataract surgery and everything else. And just using a microscope to be able to do it all really, I thought was one of the coolest things that we could operate under a microscope on such a tiny organ and then save people's sight with that. I mean, I don't know how, as a med student, I don't know how much cooler you can get when you go in there and see that. I was fortunate in medical school. I was able to quickly identify that I wanted to do ophthalmology, and I was able to seek out opportunities for research, do some research from specifically in ophthalmology. For most medical students, so if you have, it's really just showing that you can engage in that scholarly activity, though. So whether it's ophthalmology or another, area of medicine, even if you end up applying ophthalmology, I think it translates over. And if you are, pursuing those activities as a medical student, don't be too distraught if you decide on ophthalmology later and you have, some publications in another area of medicine. When you're applying, I think it's most important that you just show that willingness and that work ethic that it's going to take. So, so I did a lot of research in medical school, and then I actually pursued a rotation at Wills Eye Hospital with Dr. Eagle. So, which is kind of if you think about it, a lot of people do rotations and they do it in clinical. But if you know Ralph Eagle, he's one of the world leaders in ocular pathology, which isn't a typical thing to go into. For me, though, when I was in med school learning ophthalmology, I thought the best way that I could be the best, medical student in ophthalmology and then resident in ophthalmology is if I learned the basics first. And there's no one better to learn kind of the basics of how the eye works and see it on the microscopic level than to work with Ralph Eagle, because, he's the, like I said, world-renowned ocular pathologist where, spent a month with him in the pathology lab, but on a daily basis, you're seeing all the different anatomy and pathophysiology of all the diseases that we end up being, treating, later on. And so it gave that, kind of firm foundation in the pathophysiology of the diseases we see so that I could better think about it also from a research standpoint or innovation standpoint so that, you have to know something kind of at its most granular level to be able to then, come up with solutions to it. So as a fourth year medical student, I spent time with Dr. Eagle at Wills Eye Hospital. And that was also critical in, in addition to my mentors at UVA, but striking up an excellent relationship with him as a mentee, that he was able to, give me a nice letter of recommendation as well. So, that as a medical student, letters, most medical students are going to have, good step 1, step 2 scores. They're going to be, have good grades and, good rotation evaluations. But ultimately, some of those deciding factors are going to be the relationships you have with your mentors, and then how much they can go to bat for you. So really, and I think I listened to one of your other podcasts with another guest that said, that when it comes to, these letters of recommendation, it doesn't always have to be, that chairman of the department. Sometimes if you can get in with someone that you can spend a lot of time with and develop a longer term relationship that they can then speak honestly about you. And then when someone picks up a phone from another institution and calls them and say, hey, what do you think about, Bilal? And they say, you know what, I spent 3 months with this guy with research and in the clinic, and he's amazing. He's got a great sense of humor. He can speak well. He's great with patients. I mean, versus if you only spent a week or two with, a well-known person, they get a phone call, they may say, let me pull out my file and I'll see if I remember that one, So it's sometimes more important to just find that mentor that is going to really bring you under their arm and really invest that time in you, because ultimately that's going to reap rewards for you as a medical student. So I was lucky to have Steve Newman, Nicola Ghazi, that, I probably spent, over 4 months worth of, rotations with those guys, getting to know them when, in between clinical rotations and then research. And then spent a month with Ralph Eagle, where in that case too, it was a, one-on-one every single day with him, for the entirety of the rotation. So another time that you can, get to know them, ask intelligent questions, work with them on their interests and research. And I think those are the most important things to get to get the best letters of recommendation, is to make sure you have great relationships with the people that you're asking. So, that goes, so I'm a fourth year medical student that did a away rotation with Ralph Eagle, really loved the Wills program, met a lot of the residents and fellows from there. I came from Florida though, and, Bascom Palmer was always, on my mind. I'd heard a lot of great things about it. Never did an away rotation there, but I interviewed pretty broadly, kind of like most medical students. I think, the number I think keeps inflating on how many programs you actually apply to these days. But I think I probably applied to 30 or 40 back then in 2008, 2009. And I interviewed about 10 places. And, I honestly would say I don't think there was a single program out there that I would have said, oh man, I'm going to hate it here. I mean, I think they all, have, pros and cons to it. And I think that comes back to, what kind of learner are you? What kind of personality do you, like this city versus that city? I mean, there's so many factors that come into it. Does it have, do you do a lot of just cataracts, or do you get to do glaucoma and retina and cornea and these, how varied is the training? How many faculty are there? Is it more didactic? Is it more hands-on? So, I mean, there's so many different types of things, and each program is going to have, different parts of each of that. So for me, I've always kind of been that kind of hands-on, like to kind of, not to say thrown in the water or sink or swim, but like to have a little more autonomy. And so for me, I gravitated more towards those autonomous programs. So, after interviewing at Bascom Palmer, I really saw that would be a good fit for me. Not to say that, that any of the other programs would not, and, actually come around, because I ended up at for fellowship, one of the other programs that I really liked with Will's Eye Hospital. But for residency, I was really excited, wanted to go to Bascom Palmer. So I was fortunate enough to get my top choice to go to Bascom Palmer. Thanks in part mostly to my mentors that were able to support me in that endeavor. So moved down to Miami. So I really also was interested. I think I just finished listening to Prithi's talk about ocular oncology with you, and I initially came in really liking retina and ocular oncology, and so I actually went down to Jackson Memorial Hospital and did a internal medicine internship, which was, obviously right across the street from Bascom Palmer. So I was lucky enough that right as I got down there, I not that I wasn't busy enough with internal medicine at Jackson Memorial Hospital, but I, searched out Tim Murray because I'd heard a lot about him. I'd read a lot about him, especially from the ocular oncology standpoint. And so I was lucky to have Tim, embrace the fact that, hey, I'm going to be, I'm a first-year intern that's going to actually be at Bascom Palmer the following year, but I was already down there early, wanted to start, working with him in his lab and doing research. So I was lucky enough to start doing research with Tim in his lab on retinoblastoma and ocular melanoma, and really was able to be prolific from that standpoint in the way with his guidance of, doing research and publishing papers and really getting a great opportunity and having a year head start before a lot of people, actually came down and started with me in my residency class, just from a more of a research standpoint and getting to know some of the faculty. Especially for me, Tim ended up being a huge mentor for me over those few years. So finished up internship and did my residency down there, which was, an awesome experience. Down there, the residents have their own clinic and the emergency room, which is a really unique aspect of Bascom Palmer. It's where a lot of the great education happens because you get anything and everything coming in through the emergency room there. And the residents are kind of like the first line of defense, starting to see those patients, then having the support from fellows and faculty, for questions and whatnot. So really, I went into Bascom Palmer really with an interest in retina and ocular oncology. Obviously, I still explored other things. I enjoyed my other rotations, enjoyed doing cataract surgery, glaucoma. But ultimately, I knew I really wanted to go to Bascom. And I think I heard Nimesh actually on your talk about how going into retina from Bascom Palmer. And sometimes it's just kind of in the water down there because it seems like there's just a healthy amounts of residents that end up going into retina, whether that is, there's all the faculty at Bascom Palmer, regardless what subspecialty you want to cover, they have great faculty across the board. But I really already knew some of the retina faculty, and it was an easy choice for me. The interesting thing out of my class, there's 7 in each class, at least when I was there, and 6 out of the 7 went into retina. And part of that also may be that the chief fellows or the chief residency fellowship often comes from, internal Bascom candidates. So I think it has that rich tradition of kind of, grooming, retina doctors there. But not to say if you're interested in any other specialty, you would not be hard pressed to find great mentors in anywhere else. So ended up, deciding to go into retina, published a lot in retina. I got to know, retina faculty as much as possible. Started to look when we were applying for fellowship as, the main places I was looking at for me was I really wanted to go somewhere that did, a ton of surgery and just got a tremendous surgical experience. One of those places that's always been, kind of on my mind in that standpoint was Will's Eye Hospital, with Mid-Atlantic Retina being their retina department, mainly because they do a ton of surgery, and they also have a lot of faculty. And so for me, it was intriguing to be able to not only have, a handful of good, retina surgeons to learn from, but, talk about maybe 12 to 14, amazing world-renowned retina surgeons to learn from. Because, as a surgeon, you often do things how you were trained. And so it's nice to be able to take different parts from different surgeons that you learn from, and then make yourself into your own unique surgeon, taking parts from here, here, and here to be able to kind of, be able to really tackle anything that comes across. So I was fortunate enough to, be accepted into the vitreoretinal fellowship program at Wills Eye Hospital, where, I can't even name, I'll probably forget some mentors, but with the likes of, Alan Ho, Carl Regillo, Arnon Sivalingam, Jim Vander, all these different, Julia Howler, I mean, you name it, there's some of the, top, not only retina surgeons in the world, but also top clinical researchers and innovators in retina. And so, once at Wills Eye Hospital, I tried to continue that drive in me to continue doing research. It's very heavy clinical research there. So as fellows, we get heavily involved in that. But then also started to work with some of my mentors there that did a lot more with industry and innovation. And that part really resonated with me because being an engineer, I'm always kind of thinking about how can I make this better? How can I make this process or workflow better? How can I, come up with something to help, with this step, or how can I, help change the way we do things for the better for our patients and for our practices? And so seeing that, several of my mentors that, worked with industry and, developed their own solutions to things and really were, extremely innovative, that really got, for me, the juices flowing, from the innovation and the engineering standpoint, because it really was going through and being a trainee, you're doing clinical research, this, that, you're learning how to do surgery. But then once you kind of start to get where you have that comfort level, that's when you can really start to think, all right, how can I make this better? And how can I utilize, my own skills to, advance our field? And that got me extremely excited. We still, our practice, I joined a private practice though, but we do a lot of clinical research, and it also allows me the ability to, pursue innovative solutions. And I do a lot with a lot of the companies and medical device companies on developing new products and workflows and that type. So for me, it was really, how do I set up a career that allows me to, be a busy vitreoretinal surgeon, taking the best care of patients, seeing the most complex pathology, which interestingly, where we are, there's no academic institution near us. So the closest academic institution is about 4.5 hours south of us at Bascom Palmer. I'm in Central Florida. So we end up being pretty much the same type of caliber as an academic institution regarding, any of the complex stuff gets, sent into us, all the, pediatric stuff, the uveitis stuff, the complex retinal detachments. And so it's been nice because I'm still able to take care of, the advanced cases, which, training at Bascom Palmer Wills Eye Hospital, you get that comfort with the more complex cases. So I enjoy still taking care of these type of patients. But then I also am able to really pursue the innovation and, in that aspect of things, which I think, as I've heard from other guests on your show, it's really trying to find that balance for what makes you happy as a physician for your career. Because, we're constantly trying to get to that next step. And what you'll find is after you finish fellowship and then you're starting into the real world, it's like, all right, now, this is now my life for the next, 20 or 30 years. I think we all go into, ophthalmology and retina specifically, say, I love what I do. I, can see patients and operate on patients all the time and just, actually enjoy being in clinic. I love, the patients we see. I love helping them with their vision. And also then utilizing all the technology we have. I mean, the ultra wide field imaging, the OCTs, all the new medications we have, all the potential new technologies, say port delivery systems and everything like that, and gene therapy, subretinal, I mean, there's so much, even coming out over the next few years that's always been a intriguing part of retina, in that it seems like every year there's just new things constantly coming along. I think as a whole, our subspecialty has done very well with staying at the tip of the spear in the way of innovation, whether it's pharmacologic, whether it's gene therapy, whether it's imaging. I mean, you name it, we keep developing more and more things. So that is what keeps us in retina, is that excitement and that kind of continued with the innovation. And so when you finish up, you got to find that balance and say, okay, all right, what's going to keep me, when it does sometimes get to be a little monotonous, what's going to keep me engaged for the next 20 or 30 years? What's going to be that thing that I can devote my, spare time, outside of just clinical care, that keeps me engaged in my specialty and keeps me kind of, with that drive and that, be inspired to continue, doing this over the next few years. And some people it's teaching, that way you can, have your kind of mark over, many residents and medical students that are going to go out and take care of patients. Some people it's going to be basic science research. Some people it's going to be clinical research. Some people it's going to be, innovation, new products, new technology. So, I think every medical student, resident, fellow, and even, physician just needs to think, how can I keep myself engaged in what I do, especially, when we talk about, burnout for physicians, being a heavy thing, is I think sometimes it comes down to making sure you have that little extra thing that's going to keep you engaged with what you do.
Sure.
So I think that's a long-winded answer. Sorry to kind of my story, how I got to where I am now. And then, we could talk more about, my outside interest in telemedicine, moving forward. But that's kind of my origin story, how I got to kind of where I am right now.
No, it's awesome. I mean, I think there's so many takeaways from that are important for students to know. Like number one, I think you mentioned, I think it's important for medical students who are just getting their feet wet in ophthalmology, trying to learn more about it, to know that ophthalmology is awesome because you can do so many different things. Like you reflect on your career. You've been a part of research. You've been a part of, you travel to different institutions and learn from different experts in different specialties. And not only that, but you carried something from all those experiences, and then you get to do a mix of surgery and medicine. You get to be part of innovation. You get to use your engineering background. So I think anybody who's interested in engineering and innovation, but also at the same time wanting to continually to learn, I think that's important too. And it looks like you've done that to push the field forward. So, talking about innovation and technology is something that's always exciting. I think there's a lot of people out there who get excited about ophthalmology because of the innovation and the technology behind it. So let's talk about, your engineering background is something that's very unique. I was talking to John Kitchens last night, and he was telling me that essentially you're the Steve Charles of their generation. So that's what he said. So.
Well, that's a very, that's a great compliment. Steve Charles is something I could potentially aspire to, but I'm nowhere near that level yet.
All right. Well, what you guys are doing is really unique, and I would love to learn more about it and for you to share more about it, and really about telemedicine right now, the state of telemedicine. So, I naively understood very little about telemedicine. I think COVID-19 has given us more of an insight of what it is and how we can use it, and maybe how we'll use it going forward. But it's not, telemedicine is not just screening protocols. It's beyond that, and it's great for, I think, for what we're going to be able to do with screening, and especially within ophthalmology. But it's also some of the stuff that you guys are doing right now, which is also creating high quality access to great care for people who are in remote areas, but also when it comes to education and what you're doing with Ingenuity right now in terms of educating people who are at different institutions, with your partnership with John Miller and people at Mass Eye and Ear, but what you're doing for using 3D surgery to really teach vitreoretinal surgery at other places. So, what's your take on telemedicine and what we're going to be able to do with it going forward when it comes to screening or education or creating access to care? What's your take on that for medical students to know, and why ophthalmology plays a great role in telemedicine?
Sure. I mean, So telemedicine has been around for a long time. I mean, the reality is, even in ophthalmology, I mean, I think, I remember Julia Haller and some of the other early people in telemedicine. I mean, we're talking over a decade ago, we're talking about screening protocols to do, photos on diabetic patients to then be able to screen, patients for diabetes. So it's not a new phenomenon that, telemedicine, in ophthalmology. But, when we start to think about it, I like to think more about telehealth. I think telemedicine has a little too restrictive of a definition because, when you like you said, when you think about telemedicine, you think, okay, it's a screening or maybe it's just a way to, connect with remote patients. But, I'd argue that, COVID-19 has even shown us this even more, is that the future of medicine is going to be a hybrid type of approach. Okay. We're not, I don't think we'll ever replace, seeing a physician in person and a physician being able to, examine and, need to touch the patient to examine and things like that. But ultimately, I think that we probably can do a lot of things virtually. And so, whether that's 10% of medicine, 20% of medicine, 30% of medicine, I think COVID-19 has just shown us that we can do a lot of this kind of in a virtual space. But ultimately, I think after COVID-19, I think what the lessons we're going to learn is that, we don't need to replace everything with virtual health, but we can actually use it to supplement and augment what we do. And, because that can provide more cost-effective solutions. It could provide more efficiency. It can help provide more, easier access for patients. So, when you look at that access, that cost, that efficiency, that's where we could potentially utilize, these virtual solutions to help us with not only ourselves, but our patients to have better care and improve our health system. So when we talk about telehealth, in no way, in anything I'm looking at, am I trying to say we're going to just replace, everything the doctor and the patients do in person. What I'm looking at is how can we utilize and leverage technology to make things better. And that's what I think a lot of us in this space are really looking to do, is to say, all right, what technologies, what new workflows, can we utilize to, allow that patient to have a better experience as almost a way that we can extend our offices. So, if I'm seeing patients in my office, how can I extend that office into the virtual space to be able to provide, a better opportunity for patients? It could be as much as, I think Rishi was talking about, having a social media, footprint, because patients will often read about their doctor ahead of time. And so, it can be as easy as having a social media influence as being a telehealth, because, then patients can easily get to know you better before they actually come in and see you. It could be as easy as having, a portal, through your EMR for patients to connect with the physician. What we're looking at is a little more kind of pushing that even further. So utilizing, I like to break it down into a few different ways. One, at least in ophthalmology, we've been talking a little bit about hybrid telemedicine, okay? And, basically what that is, telemedicine, if I wanted to connect with a patient, it's hard for me to get much information just virtually talking to them and diagnose them with a retina condition, because ophthalmology in general, it's a very, diagnose what you see. So you have to be able to see and evaluate the patient. But we have so many new technologies that we can leverage that, where we don't always have to examine the patient to actually have the information to make a diagnosis or treatment decision. So during COVID, even prior to COVID, John Miller up at Mass Eye, and then Hassan Rahimi, who's out at Palo Alto Medical Foundation, we've been working on some of these workflows even prior to COVID. We'll talk a little bit about the company we started was basically a software telemedicine company, and we were starting to work on our solutions prior to COVID. It's just COVID happened, all of a sudden things ramped up very quickly. Often people will cite that, I think COVID will probably expedite the adoption of telehealth by probably 5 years at least. If you look at the adoption outside of ophthalmology, it's something like, an average of 2,000% increase in virtual visits, with some institutions having almost a 56,000% increase in telemedicine visits. So, if you look at it, COVID-19 has been the kind of impetus to really accelerate it out of necessity and need, because we weren't, physicians weren't able to connect with their patients, or patients weren't able to come in because of, fear for safety and whatnot. So the first thing in ophthalmology, I'll talk about retina specifically because that's, where my space is. Mm-hmm. We've been utilizing some hybrid models where basically I'll be in clinic in one office, say in downtown Orlando, seeing, say 75 patients. And then I'll have, 15 or 20 patients coming to one of my remote offices that, maybe is an hour away. That's not staffed by a physician, but you'll have one or two technicians there, and they get, a vision, a pressure, and then they get an ultra wide field image and an OCT. And these are chronic disease follow-up patients, your diabetics, your macular degeneration, patients that aren't needing active treatment. And that way, and then I'll actually virtually connect with them while they're in that office, in between my patients. So it's a hybrid approach, because now I'm able to, they're getting the imaging, but then we're connecting virtually. So I'm not technically there, but then I'm able to combine my in-office clinic that I'm doing in person with this virtual component in parallel. So then I'm able to, better provide a safer experience for those patients, because they won't be interacting with any other patients. They won't be there with a busy office. They'll be able to get in and out in 10 to 15 minutes versus, say, 45 minutes or an hour. So it's really trying to provide this safer, experience for them, but allowing us to do it more efficiently, more cost effective, and providing the same level of care. So that's kind of what we've been calling a hybrid approach. But then, looking even further, what's to say we can't meet the patient closer to where they are? Okay, so, a patient that is in an optometry office, or is in a primary care doctor's office, or is in the urgent care, with the technology, in the future, I see that we can leverage and have those technologies, especially as their costs continue to come down, in the multiple locations. From a screening perspective, we talk about having, a ultra wide field camera in every primary care office, almost like another vital sign for, say, a diabetic. Mm-hmm. They get their blood pressure, they get, their height and weight, and then they get a fundus photo, and then that's, evaluate whether that uses AI to, determine if there's retinopathy, or whether that's, sent to a physician that then, can quickly look at it and actually could potentially even virtually connect with the patient to educate them on their disease process, which could enhance compliance. Because what we found too is, you talk about the screening aspect of it. Screening's good, but if you don't have a good, completion of that loop to get that patient into the clinic that needs to be, then the screening program doesn't serve its purpose, because ultimately you want a high screen throughput of all those diabetics, say, but you want to make sure that you capture those few that have, referable disease, and make sure they end up showing up. And what we've seen with a lot of programs that have done this is that's the hardest part. And so ultimately we're looking at, enhancing that by allowing real-time connection with those patients while they're in the primary care office, and not just asynchronous where the image is uploaded and then, the primary care gets a report a couple days later. And so, ultimately, if we can, capture and connect to those patients closer to where they are, we can better educate them if they do have pathology, and stress the importance of why they need to then come into the office and see us for potential treatment. And so these virtual kind of consultation workflows, I think, is going to be another way we can leverage this, so that we can meet that patient closer to where they are. And it may be to say, yeah, I looked at everything, and everything looks pretty good. I'm glad they got that imaging and identified that, but it's not something that needs treatment. So, you don't necessarily need to come to my office. or yeah, it's something that needs to probably have some treatment, and this is why it's important that you come, because of, you could have the potential for vision loss. And once you get face to face, even virtually, with a patient and talk to them about a disease process they have, they're much more likely to then follow up than if they get a call from their primary care doctor saying, hey, they told me you had some diabetic retinopathy and you should see them. That patient doesn't see the urgency because they may not be having any vision problems. I mean, some of our proliferative diabetic retinopathies patients can be on the edge of a cliff about to really go downhill, but they may still be seeing 20/20 without symptoms. And so, if they don't see something going on and their primary care doctor just says, hey, it's, they wanted you to see, or we need you to see ophthalmology, they may not see the urgency to that. But if I'm able to talk to them and explain that, yes, this is something extremely severe and you could lose your vision and sight from this, that patient has a much higher likelihood of following up with us. So, trying to change those workflows to make it where we have this extension of our clinic and really creating this ecosystem within eye care that we can better connect in this virtual space, to us is going to be important. Kind of a third thing from telehealth and retina and other areas of ophthalmology that's really interesting and intriguing is kind of remote patient monitoring. So RPM services are kind of really taking hold in other areas of medicine. There's a lot of blood, obviously, with like continuous glucose monitoring and blood pressure monitoring and weight monitoring. There's so much now data that can be captured at home and allow physicians to have a continuous picture of what's going on with the patient's, physiology versus that, one visit, one data point type of thing. So we're moving, and I think Rishi talked a lot about big data as well, which I think is going to be an important thing moving forward. But ultimately, it's about capturing, more continuous data points and more information that we can, make sense of it. So, it's good to capture the data on when they come into clinic and get an image, but ultimately that's a smaller number of data points. The holy grail is that continuous data points that we can potentially get. And for retina, we already have a little bit of that with the home vision monitoring. Some students may know a little bit about 4C Home, which is basically a home vision monitoring testing, which we do for some of our macular degeneration patients. And it can actually catch whether they have a conversion from dry to wet macular degeneration, and then alert us to bring that patient in early. And studies have shown that by utilizing that device, we can catch these patients early. And we know that the earlier we catch a disease and treat it, the better the outcomes are. So, we're already doing some remote patient monitoring with that. But ultimately, some of the more exciting things too are, the potential for home OCT. I mean, you can imagine, if we now had home OCT devices that were of, comparable quality to what we have in clinic, and we have patients testing on them on a regular basis, we're having, much more continuous type of data to make treatment decisions on. So whereas right now we bring in, say, a macular degeneration patient in, and we see them in clinic, make a decision on when to treat, and then make a decision on when to follow them up. With this type of approach, we have the potential to say, all right, we're going to, monitor you from home, and then when it looks like things are changing, we can bring you in. This is going to be more important too, as we have, say, gene therapy or port delivery systems or longer acting drugs and technologies, because now we may not know, the medication or their treatment may last 6 months, but then we don't know whether they're going to need, rescue treatments in between or what. So it's like we either bring them in at a continuous regular interval into the clinic, or we leverage technology to be able to monitor those patients on a more continuous basis from home. Looking at other specialties within ophthalmology, you can envision that, we're going to have continuous intraocular pressure sensors in the eye for patients with glaucoma. I mean, there's already, I think, some home pressure devices, pressure testing devices at home, but you can envision that, say just like Google had the contact lens and check blood sugars, maybe there's a contact lens that checks, that can keep track of what the eye pressures are. or maybe there's an intraocular lens that has an intraocular pressure sensor in it as well. I mean, the cost of sensors has gone down significantly following Moore's law. That you can envision over the next 10 years the sensors we can that we're going to use within the body and the eye itself to monitor things. So so that's another aspect where I think still falls under the telehealth aspect of things, that is more than just a screening. Now we're talking about the ability to potentially make treatment-based decisions on people from home. And so these are all kind of very exciting, potentials in our field. But like I've said before, I think we're in the first inning in telehealth. I mean, COVID really pushed us into that first inning, but I think we have a long ways to go. But, we're here to continue, working on those workflows, figure out what's going to work, what's not going to work, and then how we can best, set up systems that aren't going to disrupt kind of our current way of doing things, but really augment it so that we can provide, that better service for our patients. Then lastly, I think, as you alluded to, is kind of the education standpoint. I think the education standpoint is also a very important aspect because, especially COVID-19, you can't always have medical students and residents in the operating room all the time. And, when it comes to even examining patients, sometimes having, I remember at Wills, we would, as fellows, spend time with Carol and Jerry Shields in their oncology department. And, there would be some days where there would be, 10 people in the room with a patient, following them around. The days of, even 2 or 3 medical students, residents, fellows following and attending around seeing patients is just not reality right now. And so starting to think about the same thing in the operating room. Having 10 people in the operating room observing a case just isn't happening these days. And so thinking about how education's going to change is going to be an important aspect of things. So what we've really been interested in, Dr. Miller, Dr. Kitchens, and I have been really looking at how to set up an easy way to live stream surgery. Okay, so there's a lot of more expensive ways to set up, with the IT department, but what we're looking at is really an off-the-shelf solution that's low cost that we can plug into, any type of computer device, video capture that image, and then transmit it. The cool thing, and for any medical students out there in ophthalmology, just go spend a day in an operating room with someone with the ingenuity, and you're going to be, absolutely amazed with the specialty. Because, back in the day, I can't tell you the number of times as a med student, I sat in the corner of the OR, not even seeing anything, or, looking at this small TV connected to the microscope with this grainy image and, being like, I can't tell. Or if you had the opportunity to look at the, in the side scope, it's still not even near what the surgeon's seeing. And now we have, Ingenuity, the 3D digital system, where everybody in the room is seeing exactly the view I am as a surgeon. And so that opens up, and not only that, on a 65-inch screen. So I would tell any medical student out there, if they're on the fence about ophthalmology, find someone that has an Ingenuity in their OR and go watch surgery. And I guarantee that's going to, push you over the fence one way or another, because it's just, the visualization and the viewing now from an education standpoint is amazing. Even from we've been using Ingenuity for over 4 years now, and, it offers a ton of benefits, and we won't even get into those just from a surgeon perspective. But, the other exciting part is going from analog to digital. And so we're actually going from analog viewing of a, ocular-based microscope to now a digital viewing system. So when you talk about innovation and technology, once you open up the digital space, that's primed for, augmented reality, artificial intelligence. There's so many potential ways. We're already doing, changing color filters so that we can change the different colors while we're operating to better enhance certain part of the procedures and, manipulate things in that way. So you can imagine that, as Ingenuity has allowed us to get into that digital space, and then over the next 10 years, that's going to be the platform that we can build on. And so that's the other exciting thing about, the 3D digital surgery. But Sorry, off on a tangent, getting back to the education standpoint. So it's exciting where we've been able to just use a low-cost, off-the-shelf video capture device from Magewell that we can plug right into the Ingenuity. We don't have to download any software onto that platform, which is important because last thing you want is to, crash your operating system there. And then we can plug that into a laptop and stream directly into, say, Zoom, and do live streaming of surgery directly into Zoom. And so not only that is we can do it in 2D, but then we can also stream the side-by-side images. So then if you have Zoom on your phone and stick it into like a VR headset and you have the side-by-side images, those cheap VR headsets can fuse it and you can see it in 3D. So now you can, with a low-cost device, for under $1,000 on each side of the way outside of the Ingenuity, you're able to live stream and potentially, see in 3D, different types of cases. So it opens up a realm of opportunities, not only for, say, medical school viewing and residency viewing of surgery. We've already started doing it with one of my colleagues in the anterior segment cataract surgery that's actually doing this already with doctors in Honduras to train them. So he's streaming live to Honduras. It's Dr. Kevin Barber. We got him set up with this device and got him going on it. He's really taking it and running. And he streams his surgeries live, on a weekly basis to teach, surgeons in Honduras. He can, with this, we can set up not only the video capture of the surgical screen, but then you can set up, sky's the limit. You can set up cameras on the surgeon's hands. So not only are you seeing, surgery, but then you can see what they're doing with their hands, how they're, positioning their hands. You can put it on the machine. I mean, you can put cameras anywhere, and then you can have all those tiles available for someone to watch and be able to get a better opportunity. So for us, what our goal would be to say, hey, Bilal, I know you're interested in retina, why don't you want to tune into Dr. Kitchens today in surgery? And wherever you are, whatever program you're at, you may be at a program that doesn't get retina, it doesn't have a large retina presence, or a medical school that doesn't have retina. And you say, all right, I'd love to watch Dr. Kitchens or any other retina surgeon. And you can tune in and watch him in surgery for the day. And not only that, you can ask him questions. You can interact live, with him. He can, talk people through surgery of what he's doing. So these are the type of solutions, we're really excited about from an education standpoint, because we think that, especially with COVID, but ultimately I think that, even after COVID's over, I think these type of solutions will benefit, people all around the country and even around the world, because, there's so many people around the world, surgeons around the world, that don't get, a experience with certain conditions, whether it's certain disease states or even, whether they just don't get, much experience with retina or, different ways to do cataract surgery. And so ultimately it's a way to not only train medical students and residents and, allow them to see it, but then we can allow us to teach, without any borders, around the world without actually going there, which is the exciting part. So we're looking to set up, right now it's more of a streaming and allowing people to view and interact, but ultimately, the goal would be to have, almost a whole virtual telementoring experience, so that, you could even say, all right, say you're new into practice, you're a year into your practice and you're a retina surgeon, and Dr. Kitchens or Dr. Miller, do this way to do a intraocular lens replacement a certain way. And you say, hey, I'd love to have you join me in the operating room virtually and show me and talk me through, my first case, where they can actually be viewing you during surgery, coaching you through that procedure, and even being able to potentially, mark on the screen in real time from their location and show up on yours, say, all right, grab here. So you can envision that we could set up ways that, we could enhance the way that people can telementor, from anywhere in the world, and that you can search out those opportunities where it's not just, okay, watch a video how to do a new procedure. You can have the surgeon that invented it be there in the operating room with you. And I mean, that's the exciting part is, that you could say, hey, whoever invented that new procedure, I'd love to have you join me in the OR to show me how to do it and, teach me how to do it. And that's the really kind of cool part about it all is I think that's, we're getting close to that point. I mean, I think we're only another few years away from really having a sophisticated approach to be able to provide those type of services. So, that's, I think, where the future is going with the education standpoint. And, as a long answer to telehealth, I think there's so many different facets to it that, most people don't think of and often, go straight to the screening aspect. But everything we touched on, I think, falls under the telehealth setting. And within each of those, there's so many ways to break it down even further. So for any medical students or residents or fellows or anyone else interested in technology and, see telemedicine now and what it's doing, it's also a nice time frame to say, there's no experts out there in telemedicine, in the way of saying, there's nobody that's been out there for 30 years doing telemedicine and is an expert on it. So it's also a nice time for, younger residents, fellows, or surgeons to say, this is going to be my niche. This is what I'd like to, really make my mark on because it's a new field and it's only going to grow. And so it's a nice time to get into it and say, you know what, I'm going to help shape this. It's not already been shaped because we're still in the early time frame for it. So it does give you that ability to say, all right, I'm going to put my mark on this and, I'm going to, help push our field in this direction and work with my colleagues to try to, make things better for everyone in this regard.
Just touching on all those things you talked about, which I think is the benefits of telehealth is really, like you mentioned, I think the biggest problem in medicine probably right now, I think we can all agree, is the cost of healthcare. And in terms of creating effective but efficient and cost-effective care, I think that's a nice thing that we have the opportunity right now with the hybrid approach that you're talking about. I think maybe we can help mitigate some of that. And then in terms of what you mentioned, in terms of the ingenuity, I can 100% echo that sentiment that I saw my first ingenuity case at the University of Kentucky as a visiting medical student back in July and August. And I'll tell you, I saw that one case and I was hooked. And that's pretty much, I think, what I think a lot of other options for medical students can have if this telemetry that you're mentioning goes forward. I think it really creates a lot of opportunity. I'm personally really interested. I think it's something I would like to be a part of is how do we create these telemetry opportunities not only here for people who don't have home ophthalmology departments, such as myself, but also abroad. If we're going to do global health, this can change global health too in terms of training people and without resources in other countries who are trying to get educated from people here, or how we can learn from other countries as well through this technology. So I think it's really exciting to see what happens down the road. And like you mentioned, I think we can all have kind of a role in trying to shape it or at least understand it right now, because this is the time for it's going to have its renaissance, I think. So it's really interesting to see what happens.
For sure.
So, Dr. Houston, I want to talk about HealTheia. So HealTheia is your startup company, and why don't you tell us a little bit about it? And also, how about you also tell all the medical students out there what it's like to be on that side of things, of not the industry side, but also the innovation side, and how do you have the activation energy to have a startup, and what is it like to have a healthcare startup and really find the right team, and how can people who want to be in that sphere down the road get interested in that and also have the momentum to do it?
So excellent question. And, I think that's also the exciting part of retina in general is that there's so many new areas popping up everywhere that, there's even, the interesting thing, even if you're into basic science and you're researching new compounds, there's so much more opportunity now to spin that off into even an early stage biotech company. So, whether it's technology innovation, software innovation, or even biotech, I think within retina, there's so many opportunities for, medical students, residents, and fellows as you get into your career. to explore these things. So from our standpoint, HealTheia was an idea of myself, John Miller, and Hassan Rahimi. We started the company about 2.5 years ago with the idea that we really wanted to create this virtual eye care ecosystem. Okay, kind of what I talked about, where what we want to do is set up a way that all the ophthalmologists, optometrists, even the different primary care, urgent care, anywhere where someone with an eye problem, wherever they go, that we want to have connection between those points of care. Whether it's in their house, in the primary care office, in the optometry office, in the ophthalmology office, or the retina specialist office, connecting all those people together. Because right now it's a little discontinuous. The patient may have loss of vision, and they go to their primary care doctor. Primary care doctor refers them to the ophthalmologist. Maybe they send them to the optometrist. The optometrist sees, say, a retinal vein occlusion and a cataract, and then that patient is sent to the retina specialist, and then the retina specialist may treat the retinal vein occlusion, but then also sends them to the cataract surgeon. So by that point, they've already gone to the primary care doctor, and maybe they even went to the urgent care before the primary care doctor. So they've gone to multiple levels for this one complaint. And, like I said before, if we could connect and capture that patient early on, maybe when they went to urgent care and we identified, yes, that's a central retinal vein occlusion that needs to come, straight to retina, but then we can then get them in for their cataract, and then also if they need refraction and other things in with the optometrist. So, how can we better create that referral network, but connect everyone virtually? And that's kind of always been our thought, is how can we create that glue that's going to connect everything together? So we started working on these, workflows of that, really diving in, thinking about what the future looks like. And then prior to COVID, we were in the process with our software developers to create this platform that we see is going to connect all these different players involved. So we're in the process of that. We've been going through the iterations over the past year of, with software development. If you've ever done it, it's software development, I would say there's never a finished product. So it's what you talk about, trying to get that MVP, out there, which is going to be that minimal viable product that's going to allow people to do what it needs to do. And then, obviously you build features onto it over time. So we've been in the process of getting that core standard features all built out and the workflows of it built out, so that then once we roll out, we've got that initial ability to really provide that glue with it, and then we build the features into it. So, that started before COVID, and then, obviously with COVID, that's, also, accelerated our timeline, but also, makes it a little more difficult because of COVID and the issues associated with that, with people working from home, software developers, being more remote, not in a centralized location, which slows down the development process a little bit. So that's kind of where we are. HealTheia is our goal is to, like I said, is to create that virtual eye care ecosystem. And I think it translates though into other specialties. There was a recent Amwell survey, Amwell being one of the large telemedicine companies, and what they found is the utilization of their platform is now 54% existing patients with existing specialists. So what we're finding is a lot of time the specialists sometimes are the most ripe for virtual care, because often the patient's already been examined, and now it's these days, say a cardiologist, do they necessarily, you could even record a heart sound now with a stethoscope, but then ultimately it's going to be looking at the EKG, the echo, and say the loop monitor, to determine what's going on. And so what we see is ultimately, if we can create this platform that's going to allow easy, seamless integration between all the different people with the images that can go along with that, and then the synchronous and asynchronous communication between all players, including the patient. That's what we see as a huge value, I think, as we move into that second and third inning of telehealth for our specialty. And so that's kind of where we're kind of moving towards, is providing that that next step of a platform to kind of build on. How's it like to be to have a startup? So, it's from a time standpoint, definitely it's finding your own time. I mean, obviously, a busy surgeon, in a busy private practice. So most of the time is going to be after hours. Our developers are not based in the U.S., so that's, working on time zone issues as well. So that's, there's many 12 o'clock, 1 o'clock a.m. Calls with the developers to, go through the workflow processes. But like we said before, it's about finding that other thing that kind of sparks you to keep kind of having that interest. And for me, having that hour or two phone call where we go through all the nuances of the workflow, how we get this to go, and working with the developers. For me, that's, an exciting. I mean, in undergrad, I almost switched from biomedical kind of materials engineering into software engineering because I love the coding aspect of it. At this point, I'll say I'm not a coder. I mean, this was back in the early 2000s, with C++. And, but I love thinking about it as a puzzle. And so to me, that's the exciting part of software development, is really solving that puzzle. Even if I'm not coding it, I can work with the software developers to figure out the pieces of the puzzle and how to fit things together. And so for me, that keeps me excited about, what we do, and that I can come up with a solution. And then when I roll out the test phase of the product and we see how it's working and everything else, it's exciting to see. I didn't necessarily code and build that, but I, mentally and framework and kind of workflow built that. And so it's exciting to kind of create that, that new product. So, it's just like, discovering a new molecule or something else. For me, creating something out of scratch that wasn't there, and creating it how I thought in my mind it should be, and how my partners thought it should be. That's an exciting part. So that really keeps me, kind of in that part we talked about as the exciting aspect of what we do. But yes, it's definitely, it's all about, what you put your mind and your passion to. I mean, ultimately you find time for things you love. And so, whether that's your own health and wellness and everything else, I mean, there's 24 hours in a day, and we all have to decide, what aspects are important to us, our jobs and careers, our families, our health and wellness, and then, other things. And, ultimately, if it's something that you want to do, you find the time to do it. And, and it doesn't have to be at the expense of other things. I mean, it's about trying to carve out the time, whether it's first thing in the morning before your kids get up, to have the time to do it before your spouse and your kids get up, or whether it's, late at night when everyone's gone to bed, or maybe it's carving out some time, during your clinic where you may not have patients for an hour. I mean, there's more than ample time, and you just have to, find where it works for you and make that time. And, that's harder. That's definitely harder for med students and residents and fellows, because things are a little more structured in what you use as your time. But I think it's beneficial for, for you guys to start thinking about, once you get out into a career, it doesn't have to be that it's just, head to the ground now, just see patient after patient after patient. Like, you can start to carve out how you want your career to be. And I think that goes a long way in preventing burnout and other things, because you feel like you're more in control of your time. And I think that's another benefit of ophthalmology in general, is that I feel like we can have a little more control of our time, because, we're not constantly in the hospital, having to, round and be in the operating room in the hospital and everything else, that we can, shape, whether you're in academics or private practice. I think if you want to do it, you can create that time and find that time to do it. So from a startup standpoint, I think everybody's different, whether they have the heart for entrepreneurship or not. For me, I love the excitement of innovation and coming up with new solutions and products. So to me, it allows me to really utilize that analytical thinking that was ingrained in me in my engineering career, and really start to utilize that by trying to think of how I can help, advance our field and what we're doing.
Yeah, I like that. I think it's one of the things that you mentioned that ties on to what we talked about earlier too, is that if you have that spark of energy because it excites you, if the passion behind the initiative excites you, then I'm sure you don't feel tired by it or drained by it. And instead you feel excited by it. And I think having that time and the time cost of opportunity to have the creativity is important. So I think it's a really inspiring thing for all of us to learn from, and hopefully I think all of us have a little bit of innovation and the tick in us to really see something carried through with the vision. And I think what you all are doing is outstanding, and it's really exciting to hear about it. And I hope other medical students that are out there who are interested in ophthalmology or interested in technology or interested in global health or education or creating sustainable solutions to complex issues are inspired by this chat. So Dr. Houston, I want to thank you for taking time to talk with me. And it was a true pleasure to sit and listen to you.
Thank you, Bilal. And like I said, I love what you're doing here as well, because I remember sitting in your seat over there, trying to figure out how to navigate this process, and searching out online forums and everything else. I'm not even sure if Student Doctor is still out there, but I remember being on Student Doctor trying to figure out what this whole process of applying to ophthalmology entails, and trying to get advice for people from people that have been there and done that. But it was even back then with that forum, the ends are small, so you're only getting a few different opinions. So it's really nice what you're doing to get a large swath of people out there from different experiences that can provide that input and advice to medical students and residents. So I love what you're doing. It's a great platform, and I binged on your show in the car on my way to work yesterday and today, so I was able to quickly listen to a few, and all the people you've had on that I listened to, Rishi, John Kitchens, and Paul Chen. I mean, those were a few I listened to that were, I think, had just so many pearls of information that any medical students out there, I think, listening to your podcast, I think are going to pick up some amazing things and learn from some of the best physicians out there in our space.
I hope so. And likewise, and it was a great time to have you as one of those guests as well, and hopefully come back in the future. So I hope we stay in touch, and it'll be exciting to see what happens with your initiatives down the road.
Thanks, Bilal.
All right.
Thanks for having me.
Bye-bye.